All right, now that we have a better idea about surfactant, intrapleural pressure, elasticity, all of that good stuff, we can better understand pneumothorax, where air gets into the intrapleural space, and atelectasis, which is just where the lungs collapse. Often people confuse these. They're very related. Pneumothorax might be the leading cause of atelectasis, but technically they're different. Pneumothorax has 3 different versions. Atelectasis has 3 different versions. Not just kidding, it actually has a 4th version, but the 4th version is kind of rare. All right, pneumothorax. Pneumo, air or breath. Thorax is your chest. So when air gets inside of the chest. So bunch of different ways it can happen, but here's my intrapleural space, and we can see way too much air, more than there should be. You can see this on the MRI. If this was pleural effusion, it would be a little bit more opaque, but this is a very radiotranslucent, so here's my air, should not be there. Now, if something is a tension pneumothorax, it's like the more severe type of pneumothorax. So here there's way too much. You can see how like translucent this is because, again, the air shows up as black. So if there's way more air than there should be, it'll be a little bit darker. So 1, that's a little bit darker than we have over here. And 2, there's so much pressure that it pushes the entire trachea over to the left a little bit. You can kind of see that a little bit. It's deviating towards the left. 3 basic types. So 3 basic types, but kind of 6 basic types. Closed is spontaneous, open is traumatic, and then tension. We're mainly going to go through spontaneous, traumatic, and tension, but some people call them closed and open. So closed is where you haven't been stabbed, you haven't been shot. You kind of have a leak in your lungs, and air is leaked out into the intrapleural space. The traumatic, you got stabbed, too bad. Now there's air in here. And then tension is just where there's a one-way valve. So maybe the main way of tension is you get stabbed, and so like air can get in, but for whatever reason, air can't get back out. But you could have a tension pneumothorax where it's actually just air leaks from the lungs and it's not allowed back in. That's also possible. So both a spontaneous and a traumatic pneumothorax could lead to a tension pneumothorax. So spontaneous, the name is helpful, right? So pneumothorax, air in the thorax and the interpleural space where it shouldn't be. Spontaneous, this one just kind of happens, right? So maybe people have too much air in their lungs, meaning too much pressure, like emphysema. Maybe they have weak tissues, like Marfan syndrome or something. Maybe they have a cancer, and that causes a weakness in the lining. But air leaks out of the alveoli. This forms air blebs. If it's a big air bleb, we call it a bulle. And here's just a picture of all of that air in the intrapleural space. It can cause atelectasis, meaning it can collapse the lung. But so we get this bleb. There's a break in the lung lining, gets in the intrapleural space. This is the hole in the visceral pleura. Now this buildup of pressure here. Now this buildup of pressure, we kind of saw here, it doesn't necessarily have to be equal to or greater than atmospheric pressure to collapse the lungs. Because if you think about it, we said earlier that it needs to be -5. Well, if too much air gets in here and it goes to -1, right, it's still below the 0 here, but that still might be enough to collapse this. So we call it primary spontaneous pneumothorax if it just happened for sort of no reason. Interestingly, we find that this happens with thin, tall males in like their teens, and if you hold your breath, it's going to increase the pressure and make it worse. I think of my friend here. Secondary is where there's just an underlying condition, weakened connective tissue with Marfan syndrome or cystic fibrosis, emphysema, lung cancer, any other underlying condition makes it secondary. Traumatic is, well, it's trauma related, right? You got shot, you got stabbed, you fell off of you got into a car accident. This is where something rips through your fascia and your parietal pleura, and then air just leaks in from the outside atmosphere into your parietal space. A tension pneumothorax, again, this could come from spontaneous, it could come from traumatic. This is where there's like a one-way valve. So just think of like a really shitty inner tube. You blow air in, and then if you're not holding it, air will just leak right out, right? Well, now think of like a nicer, higher quality air mattress. You breathe air in, and then if you take a break for a second and talk to your friend, air shouldn't leak out because, again, air is only allowed in one direction. So with a nicer, higher quality valve, it's one way. You could have that happen, again, either with tension or traumatic, just I guess it depends on the details, that there's a rip in the lungs or in the thorax or something. Air can get out, but when air tries to come back in, it kind of pushes this thing shut. Very similar to the valves we have in our heart. Where if there's too much pressure, they then close the valve. So too much pressure can close this flap. And obviously, this is going to build to a higher The reason this is more dire is because it builds, this one-way valve means more and more pressure will just build up, build up, build up, build up, build up until it becomes enormous, and then it absolutely will compress the lung, and again, it can shift the trachea over to the right side. It also can get so large that it actually compresses on the heart, and prevents filling of the atrium or ventricles, or contraction of the ventricles. And we're seeing it on this side, but of course, everything we're saying could also, you can get stabbed on both sides of your body. Treatment for a tension pneumothorax, again, this is the building pressure, so we want to, time is very important here. A needle decompression. So you're going to stick a needle in here or stick a needle in there, and you're going to withdraw the excess air. Often you'll do this in a military setting. Someone gets shot. That's going to be really useful. So atelectasis, atel means incomplete. Ectasis means extension or dilation. So in other words, your lung collapse. So 3 major types. I mentioned that there's actually a 4th one: obstructive, compressive, adhesive, and contraction. So for obstructive, we have kind of like, let's just say a mucus plug, or you swallow a hot dog, it goes down the wrong tube or something. That actually happened. I was at Thanksgiving at my friend's house in kind of the middle of nowhere, and the dad was a doctor. He got called in because somebody swallowed a hot dog, and I thought, how do you swallow a whole hot dog, goes down the wrong tube? And 2, who's eating hot dogs for Thanksgiving? Anyways, so often this is post-surgery as well. So the anesthetics of surgery cause extrabronchial secretions, which can act as a plug or tumor. There's lots of things that can plug up this, but basically air is not getting in. Compressive is basically what we just talked about: pneumothorax or pleural effusion. So air or fluid is compressing on the lungs. Adhesive is you don't have surfactant, and this is just you have too much fibrosis. So like a restrictive lung disease, interstitial lung disease, and there's too much recoil. So we have a picture of obstructive, compressive, adhesive, and then the contraction. Technically as well, with I don't usually see this in chest x-rays, but the collapse of the lung, the decrease in volume can actually, so normally we know if it's a tension, it should shift the trachea in this direction if I had a tension over here. But actually, if it's atelectasis, sometimes the decrease in volume could actually cause the trachea to shift towards the side of lung collapse. I don't usually see that, but I've heard it's possible. Obstructive, we have a big old mucus plug. Think about this. If air can't get in, what are the things collapsing the alveoli? Surface tension and elasticity. What are the things that are keeping the lung open? It's the pressure shown here, and it's the negative vacuuming suctioning power of the intrapleural space. So if we take away any 4 of these, this is going to explain our 4 atelectases. So the mucus plug means I'm going to have no more air, no more air. So less outward push of air means that I'm more likely to collapse. Compressive, I have either positive intrapleural pressure, like a tension pneumothorax, or just have a slightly, smaller absolute value of my negative intrapleural pressure. So we can get rid of this a little bit because of an effusion pneumothorax or tumor or something, and that's also going to cause a collapse. Alternatively, the LS ratio is less than 1.5. We don't have enough corticosteroids. Moms are diabetic. It's a C-section baby, anything like that. And the no surfactant means that the surface tension is going to be larger than this, and a larger surface tension is also going to cause a collapse, or potentially cause a collapse. And then contraction is maybe you have too much, you had cancer, you have radiation, you took too much bleomycin or busulfan, you have, you inhaled too much coal dust or something, or just, idiopathic pulmonary fibrosis, too much elasticity. This can contract stronger, and a restrictive lung disease, and this is also going to cause a collapse.